morning once again, in case you're just joining us. But if you have been with us since we started the show, we really appreciate your time and company as we shift gears into the health segment this particular Wednesday. And like I told you when we were starting in the morning, we'll be dissecting the transition into what we now call the new dawn in the health system. Of course, we know that it's just this month, when we were starting the month of October, when the country fully now shifted from what we used to know as the National Hospital Insurance Fund to now the Social Health Authority, which is in charge of three critical funds that we will be discussing, also looking at the status of service delivery at the grassroots levels, at the hospitals, at the facilities where you're going, what has been the situation, and of course, what is going to be happening going forward, especially considering the complaints that have been raised when it comes to still concerns about the out-of-pocket payments. We will look at the hiccups, and of course, any concern that you have, you can be part of this conversation. Join us and share with us your comments and your thoughts at Citizen TV Kenya at Safin_Achieng, and I will share that with my panel, which actually are the right people to have for this conversation. I'm having a sit down with Dr. Patrick Amoth. He's the Ministry of Health Director General. We appreciate your time.
Thank you.
Karibu Daktari. And we're also having this sit down this morning with Dr. Abdi Mohammed, the chairman of the Social Health Authority. Karibu.
Thank you very much.
All right, so we are talking about the Social Health Authority, and critical is also the Social Health Insurance Fund, because that is what many Kenyans have been really asking a lot of questions around. Of course, there is a lot when it comes to SHA, which we will dissect. But let's begin from the very basic, because I usually like to take this platform as an awareness platform for people to understand where we are coming from and why we are going in the direction with which we are going into. And let's get to understand why this transition was necessary in terms of the difference between what we used to have, the National Hospital Insurance Fund, and now what we are into, the Social Health Authority, or if you like, the Social Health Insurance Fund. What's the key difference? Why was this even necessary? Let's start there.
Thank you very much. I think it's good to start with why the change. And why the change is not just from NHIF to SHA. That's not the only thing that has happened. So you need to look at the broader picture of the changes that have happened. There were 4 laws that were enacted last year, October. The 4 laws were trying to address the health system holistically, rather than just doing an amendment at NHIF, which we have done many times over the years. So we wanted to address the whole ecosystem, because just addressing one bit of the health system, which is the health financing alone, will not address the challenges that we face as a country. So the 4 laws, for the people who might not know, the Primary Healthcare Act, the Digital Health Act, the Social Health Insurance Act, and the Facility Improvement Financing Act. So what each of them, and I think the DG will now expound on each of them, just to show you the WHO building blocks, which is very important for any health system to stand on its own. So treating just one part was not enough. The essence was just to address the whole health ecosystem.
It was sort of like a holistic
Exactly. So it was meant to address the whole building blocks, rather than just addressing, doing an amendment, which has happened. Many people might not realize, but in 2022, the National Health Insurance Fund Act was amended to the it was the National Hospital Insurance to National Health Insurance. And it was taken to court because of issues, the amendments that were there. So that's why we have tried to address the whole health ecosystem rather than just one. But we will come to what is different between SHA and NHIF. But I would like the DG now to just expound on the 4 legislations.
Thank you, Chair. Dr. Abdi is also my chair because I also sit in the board of Social Health Authority, so I'm here with my boss. But thanks, Chair, for trying to elucidate as to why this fundamental shift from what we have had is to be able to look at the entire ecosystem in health delivery, because there are various pillars of the health system. And based on our situation analysis, then we decided to focus on 4 key areas. That is health financing, and that is what she has talked about, the laws that came into being. Then human resources for health, or health workforce. We know very well that by 2030, as a global community, we'll have a shortage of nearly 8 million health care workers. 80% of this will be in low middle income countries, specifically sub-Saharan Africa. And then we have also focused on health products and technologies, local manufacturing of medicines and medical products and technologies, but also the governance. So in terms of the laws, if you look at the Social Health Insurance Act, is basically to be able to move from what we have had, catering for a small segment of the population, basically 20% of the population who are salaried, to include the 80% who have been left behind. By definition, universal health coverage is basically that everybody has access to healthcare services they need, wherever they need them, without suffering financial hardship. So for a long time, we are focused on 20% of the population and left 80%. So in terms of the Social Health Insurance Fund, if you look at that, it's basically to be able to ensure that we have a predictable financing mechanism. Prepaid is the best for social health insurance, and social health insurance means that everybody is taken on board. That is why we have contribution. Now we are focusing more on contribution from the informal sector, which had not been forthcoming. If you look at the primary health care fund, for a long time, our primary health care facilities have been chronically underinvested, underfunded, underutilized. Mainly the domain of development partners who chip in once in a while to ensure that they run. And primary healthcare system is the best way to be able to deliver universal health coverage, because primary healthcare systems are comprehensive, they're integrated, they promote inclusivity and equity and ensure that nobody is left behind. And the primary healthcare fund, and the government is putting its money where its mouth is entirely free. All that is required of you is to be able to register.
So it's funded by the government?
It is fully exchequer funded.
How much do we have under that fund? Right?
Under that fund, we have
currently
4 billion.
And that happened because of the finance bill,
yeah.
Which
the target was?
The target was up to 30 billion.
30 billion.
Yes.
That's a huge deficit still.
Which we will be able to have the supplementary budgets that will be coming forth, and we will have more funding that will be coming to the primary healthcare fund.
And for the emergency, chronic and critical illnesses fund, is it also funded by the government?
Yes.
Fully funded by the exchequer again. To be able to cater for emergency services, which was a law that the Constitution passed in 2010, declared that Kenyans ought to be able to have access to emergency services. Since 2010, that has not been actualized. This is the first time that we are trying to move this forward to ensure that Kenyans can be able to have 24-hour emergency services, ensure that we stabilize them before they move to the next level of care, without payment from their pocket. And this is supposed to basically cure what you used to have. Very many times you have patients stuck in ambulances, in parking lots, in hospitals, waiting for relatives at 2 a.m. to be able to raise 400,000 shillings. Where the hell do you get that kind of money at that particular hour of the night to be able to access service? So it's basically to ensure that people can be able to access emergency services when they need it. And the beauty with that is that you can access emergency services at any facility, private, faith-based, public, registered, not registered, empaneled, not empaneled.
All right.
Yeah.
I'll come back to you, Dr. But allow me also just ask something that has been very pressing for many Kenyans. I'll be offending a majority of them if I don't start there. Let's talk about the Social Health Insurance Fund. And I'll just use an example that is very recent on page 2 of the Daily Nation. It's an Nakuru-based surgeon who is actually painting a very grim picture of the state of healthcare. He's saying that it was, while he was making a submission via video link in hospital, he was saying his name is Dr. Benjamin Magare Gikenyi. He told Justice Bahati Mwamuye that he was attending to a stage one cancer patient who could not undergo surgery because there was no pre-authorization, yet the patient had paid his NHIF contributions. And of course, I'm just using this example to also add on to the very many reports you've seen also on social media of patients decrying that they cannot be able to access services because of the hiccups, especially when this transition happened. Why are patients still paying out of pocket, yet there was this dream that was supposed to be delivered that people are very optimistic about? What is happening, Chair?
So the first thing that you need to realize is that doctor is a petitioner. And it is a case that he has lodged on the digitization. So that's the first thing that you need to realize, that he is prosecuting his case to the judge that there is a problem. But if you go to the same facility that he's in, which is Nakuru PGH, I'm assuming, and we see from the data, the dashboard, they have been attending to patients. Operations have been ongoing in the same hospital. Dialysis patients have been treated in the same hospital. Mothers are delivering in the same hospital. So sometimes it's good when people, something is written, it doesn't mean that's the truth. You have to look at based on what. It's his prosecution of the case, is he's pleading to the judge, telling him that there's a problem, but at the same time, the data speaks differently and the reality.
Which is a
so
given.
What's happening
in the health facilities across the country? Do you want to say that there is no problem based on the reports that you have seen yourself?
Far from it. I will be lying if I tell you there's no problem. There are some facilities still who are having challenges, and they are being addressed at the branch level. So that if you have, sometimes what we have is user issues. So you have been given the login details, you have been given all the necessary training, but you will find not all hospitals are equipped similarly in terms of personnel with ICT knowledge. So those are the ones that we are hand-holding, trying to see where are the issues. But also you will find there are people who haven't yet registered. So if you have not yet registered and you have not gone into the system, of course the system will be difficult to notice you or to know that you exist. So what you need to do is, and that's what we have been pleading with the public, just register. Before even you reach payment, just registration alone will give you access to many things, including primary health care. And if you have paid and you are seeking services, it will be in your interest that you register. You do the registration and you complete. And more importantly, what is happening also, because I will tell, these are problems that we are facing every now and then. You will register, but you forget to add your spouse. You forget to add your dependents. We cannot declare for you. Because currently we allow multiple wives. So, but we are not the ones to tell you add so and so, add so and so, and leave so and so. It's not us. So what we are appealing to the public, and it doesn't cost anything for you to register. It's just *147#, or you go to afyayangu.go.ke. So that is the thing that we are appealing to the public. And facilities that are having challenges, we are appealing to them to reach out to the branches, because in every county we have a branch, if not 2 or 3 in this country.
All right.
So we have no challenge in terms of people having access to helping them sort out their issues.
Right. Dr. I'll come back to you to just give me the status of registration as per now.
Yes.
In addition, let me just add to that, what Chair said is that if you look at the data that we are picking from the dashboard, pre-authorization actually has now, the time for pre-authorization has reduced to an average of 78 minutes, 1 hour, 20 minutes. You remember before people used to wait for 3 days, 1 week before they get pre-authorization. Now you wait for 1 hour, 20 minutes. And if you look at the pre-authorizations that are being lodged, most of them are on dialysis. So imagine you go to a facility, you require dialysis within 1 hour, 20 minutes, that decision has been made that you should be able to receive that service. So as much as the doctor is trying to point that there are challenges, we should also be able to accept where progress has been made. And on the flip side, you look at the case like this case of that was done at Coast Provincial General Hospital, that lady with a heart problem. That is a positive story. So if we should also be able to compare.
Both sides of the divide. But where it pinches is where it's not working. And this is what we are trying to address, yeah? Where it's working fine, that was the dream, that was the ambition, that is where I wanted to go. But the places, the few issues that are emerging are the ones we are trying to address. And, you know, it is such incidences that are casting a doubt on whether, you know, the system has the ability to really deliver on its ambitious objective of access to healthcare for all. In the words of a very common mwananchi, hii shift inatusaidia kweli ama inatuumiza? Is it really working? How would you answer that, Mama Mboga?
I'm happy you said a few issues. Because if I come to this studio and Citizen, I will find issues, 1,001 issues. But I cannot come and say Citizen has a problem, all this, just because of a few issues. And I'm not saying that the few issues are acceptable. It's just that there are challenges because we have moved, remember, from manual system to digital. So no one is carrying a card. You need just to identify yourself with your ID. Just saying, I am so-and-so, my ID number is so-and-so. And that is the whole essence. So that we move away this idea of people carrying many cards. And I can see from your photo, you have a card written SHA. There's no card that we have issued with anyone. And there are people who are now creating those fake things outside. So you help us create the true picture, that there are no cards. You need your ID and you need to register. So to come to your earlier question, which was what's the difference between SHA and NHIF, there are a lot of changes that, for me, I find them to be positive and progressive, which was meant to address the problems that we had with NHIF. The first thing that you need to realize is NHIF was a members club. For you to get any services under NHIF, the first thing you needed to do was register and pay. There was nothing you were entitled to if you have not done those two things. You had to pay. Two, when you pay, you had to wait for 2 months. If you are in the informal sector, and if you are in the formal sector, you are to wait for 1 month. For SHA, there's no waiting period. You register right now, you pay, you get services. No waiting, no discrimination on age or condition. Whatever disease that you have, it doesn't matter. There are no exclusions and there are no age restrictions. If you look at again what was there in terms of the contribution, I know where people are saying NHIF had bans, but that banding was very regressive. It was punishing people who earn lower amount. Even if you look at your organization and ask the people who earn 35,000 and below, they have a reduction in their premium. So it's not everyone who has gotten an increase, and the 2.75% is meant to equalize so that there is equity for all of us, rather than someone paying 0.01% of their salary and someone else is paying 5% or 10% of their salary, which was very unfair and very regressive. If you look at who benefits from SHA other than the people who have registered, is any Kenyan who has registered will benefit primary health care. That's it. You don't need to do anything else. All you need to register, get access to free primary health care in public, private, mission hospitals. Previously, there was nothing like that. For primary health care, for NHIF beneficiaries, you needed to have contributed and paid. Emergency, you don't even need to register. As long as you need emergency services and you have found yourself in an emergency situation, the hospital, the SHA, they need not know need to ask whether you are a member or not, or whether you are registered or not,
and
or whether you are
contributing.
You don't have to pay anything because you have found yourself in an emergency. And that's what he talked about, the issue of the law. If you look at on the issue of administrative cost, and this is one thing that people need to realize, for the first time in a government organization, the administrative cost has been capped. What do I mean? SHA can only use 5% of what it contributes, or what they receive as contribution, and what they receive from Treasury. Previously, when NHIF started from 1960-something, it moved from 80%, 60, 50, as late as recently, it was at 15%. Mm-hmm. And this 15% is what they just managed to use. There were no limitations, there were no rules, so the management and the board could use as much as they wanted. For SHA, the amount is fixed at 5%. Beyond that, you cannot use. So meaning 95% of the money that you collect will go to service delivery. Mm-hmm. And that means that we have at least the money available for patients.
All right.
So as a SHA, we don't have the issue of trying to play around.
All right.
So
let me just take you back on what you have said. You've talked about, equity is one of the key objectives of this particular transition.
Yes.
But I want you to convince, for instance, somebody earning 100,000, why, initially they used to pay a maximum of 1,700. Now it's going up to 2,750.
Yes.
What equity means to this person?
So what it means is now he's paying as per his ability to pay and his earnings. So it's equal to the person who earns 20,000, who is paying 2.75%. It means that you are paying now your fair share of contribution. So
you want to say they used to underpay?
Yes, exactly.
That's the perception?
No. It is not the perception, it's the reality. What was happening is, we just have to be fair. If I'm paying 10% of my income and you are paying 0.01, between the two of us, is that fair system? It's not.
You tell me.
It's not a fair system, and this is just proportionate. So you pay proportionately to your income. If you look at payee, which people are not looking at, comparing, payee is a progressive taxation, meaning you earn less, you don't even pay. Below 24,000, you pay nothing as a payee. But you earn $1 million, you pay 35%. So meaning it moves from 0 upwards. 5, 10, 20, 25, 30, 35.
All right.
That is now a progressive taxation.
All right.
Basically, it's everybody carrying their fair share of the problem.
But one of the grounds that was used to even challenge this transition was the fact that there was a feeling that it was placing the burden on those who are salaried compared to those who are in the informal sector.
On the contrary, the courts actually applauded the ministry for thinking about the concept of solidarity and equity and ensuring that everybody can be able to carry their fair share of the weight so that we can be able to move progressively as a country.
Right. So let's talk about this majority. But in addition, let's talk about this majority, this 80%, the informal sector that we are now seeking to bring on board, the ones that were neglected in the previous dispensation. So there's been questions about how you're going to get money from this population. There's been criticism on even the means testing instrument that is going to be used to decide how much they're supposed to be paid. For example, Njeri's house girl who is paid in cash or through M-Pesa, how are you going to get money from this house girl? And how are you going to ensure that even them, they pay what they are supposed to be paying? So that it's equal for both cadres.
And the sad reality is the people who have taken us to court, stopping us from collecting from the informal, are the formal guys. The people who have gone to court and said, stop this, you are forcing people to pay, are the formally employed people, starting with some of the people who have gone to petition. So for us, what we are saying is now It's for everyone to come on board, and it's mandatory to begin with. So we are waiting for the court to rule on those clauses that has allowed us to levy that even to the people who are in the formal sector. For people like house helps, you are able to pay for them. And if you look at our system, the portal for employer, there's a place where you can pay for people that you have employed formally or informally as a sponsor. So it is you and I who should be able now to bring on board and bring up this idea. The idea is solidarity, is to push this basket to have as many people as possible, then increase the benefit because there are enough resources. The fear was the money will be stolen. I have told you the maximum amount is 5% on administrative, 95% is for service delivery. Okay. And the other thing that people need to realize is there is no one who can pay out of pocket cash for health. It is expensive. It's very damn expensive. It's almost impossible to sustain, even if you are wealthy, to pay cash. For example, dialysis. Paying 10,650 twice weekly is not, even if you earn $1 million or $2 million.
It's not sustainable.
It's not sustainable. So what I would urge the media is to educate now, help us educate the public.
And that's why you're here, so that you answer these questions.
On the importance of us pooling our resources together and pooling our health needs. Because the reality is not all of us need health at the same time. But not all of us will remain healthy throughout their life. There's a time you will need.
That you will need the service.
So that is the whole idea of solidarity and pooling of risks and pooling of health issues.
Okay. And that is why you find even developed countries like the United States of America cannot be able to achieve UHC despite their wealth, because there's no concept of solidarity that you can be able to support your brother and sister so that you can be able to have a bigger pool, then we distribute the risk equally, and then it becomes sustainable. So in the United States, still out-of-pocket expenditure is huge, and healthcare expenses are very, very huge. If you look at the metrics in terms of indicators for the United States vis-a-vis some of the developing nations, you will be surprised. So it's a question of ensuring that everybody is brought together into one common pool, we spread the risk, and then we can be able to expand the coverage in terms of the services, and then we'll be able to generally have a healthy population. And in case of any shocks thrown at us, then we'll be able to have a very resilient system that can be able to absorb that shock.
All right. It's been days since this transition happened, and we're still facing a bit of hiccup. Some feel we rushed this transition. Why couldn't we have started with maybe piloting it in a few counties, see how it's working before we went full-blown national rollout? Do you think we rushed this transition? Because how come we're here? Things are still not working in some places.
No, you see, waiting would have meant that no one benefits from primary health care. Waiting would have meant no one benefits from emergency. So waiting would have meant we just remain with the club that we had, which was NHIF. And I just want to disabuse this notion that the NHIF system was working perfectly and never had any issue. It used to have. There used to be blackouts for 2 days, 3 days. There used to be outages of the system for even sometimes hours. So what we are facing is the same thing. Yes, we started, the beginning was not as smoothly as anticipated, but from week 1 to date, there is no day we had the system down for even an hour. For even an hour. What we are having is user issues. Individual challenges, certain hospitals, because the reality is there are almost 8,000 facilities that are using. How come you only pick 1 or 2 or 3? You see, if the system had a problem, 8,000 wouldn't be on the system using. So the fact that 1 or 2 will have a challenge, yes. The fact that there will be 1 or 2 or 3 patients who can't find themselves, yes, for sure. Out of 13 million, you will have. And you might find those are the people who are not yet even registered. There are people who are still being onboarded, and there are still who have not yet onboarded their...
What is the status of registration as at the latest numbers you have?
13 million.
13 million.
Yes. People.
In terms of the transition, let me also add that it is not a rushed transition. In fact, if there's any fundamental decision that you have taken as a country that will be able to leave a footprint for many, many years to come, is the decision to be able to roll out all in one go. Initially, in the initial phase, the first 1-2 weeks, it was a bit turbulent. We have steadied the ship going forward. If you look at even from the situation room of the command center, if you look at the number of complaints that are coming, they are reducing by the day. And as Chair says, 91% of the facilities that are registered by the Kenya Medical Practitioners Dentist Council are onboarded. What an impressive number. But we are still dealing with problems, and we know that during transition moments you are going to have challenges. What we need to do and agree is to work collectively with the facilities, with the SHA offices, with the providers, with the Kenyans to be able to address these individual complaints. Otherwise, for me, I think we have laid a very solid foundation for delivery of and achievement of universal health coverage through this declaration that was made that we begin on 1st of October.
If you look at the difference between the target that was 50 million registered under SHA and about 12 million households, and what has happened, 13 million.
You know, as Kenyans, the way we do our things. Very many people
isn't it sending a strong message?
No.
The complaints coming in, people cannot access services, the registration is still sluggish. How do you...
Can I explain? The 13 million that we have are adults, not children. The dependents are around 200,000 or 300,000 who have been onboarded. So meaning those are adults who have not yet either added their dependents and their spouses.
So this 50 million was inclusive of the dependents?
Unless we have another country with a different population.
That is important for the interpretation of the gap.
50 million is everyone, including the one who was born recently. So meaning...
Even now.
Exactly. And if you look at our population pyramid, you will find majority are children.
Yeah, we have a
below 18 years old. Those are people who need to be added. And the moment you add them, then you will realize if these 13 million just add their dependents actively, we'll move to 40-something million, for sure.
So it's not lack of, confidence, people waiting for the system to stabilize. Kenyans are still like, is this thing really working? Why should I register? They're still a bit skeptical about it.
Far from it, because every Kenyan has an idea or has a relative or a person who is benefiting in one way or another. Whether it's through dialysis, whether it's through cancer, whether through outpatient. All we need is, it's you guys now to find out. Actually, the people who are going to hospitals and being given services, and ask them whether they are benefiting. And that's the thing that we need to realize, that it's not, it's your interpretation is what's now, and what is the word? Focusing on the hitches is now what even now makes some people who might have wanted even to join now be hesitant. And that is the role now.
But the hitches shouldn't be there to begin with, just to be fair. I mean,
there's no perfect system.
Even in an established system, you still have hitches here and there.
And that's why I told you for NHIF, we used to have the same hitches.
But also, if you look at the consumption in terms of the benefit package, the largest benefit package that is being utilized by Kenyans is inpatient. But the noise that comes a lot, and which is understandable, is from dialysis and cancer patients. Dialysis is second in terms of consumption. But the largest number of Kenyans who are seeking services is for inpatient, that is for medical, surgical reasons, or for maternity cases. And those ones are getting similar service, except you also find that there are also these groups of patients who have organized themselves into very, very strong units, and they have a very loud voice. So that should not be able to silence the other majority who are receiving seamless services without any problem. But all I would want to say is that we need to be able to address the challenges collectively. Instead of fault finding, when the challenges arise, we need to be able to look at them, troubleshoot, get a solution, and move forward, because the foundation is now well set. And we have really left I can say the aircraft has taken off from the runway. We are in flight now. What we need to do now is to reach the cruising speed, and everything will be okay.
You mentioned about the Kenyans who have registered. I also want to hear how many hospitals have been onboarded, the public, the private, and those who have not been onboarded. Is it because of failure to adhere to the regulations, or what are the real issues?
So the public, we have onboarded all of them.
All of them.
All of them. Mission, almost all of them, because they don't, they work with SHA, they don't have that luxury. Private, we have onboarded almost 3,000. But for the private, if you realize there are some which do other services. Like a facility has taken a license, which is in order to do hair transplant. For that, we don't have any benefit to that kind of benefit. You will find an individual doctor has taken their clinic, he's a consultant, so there is no contractual obligations that we can have for them to provide services. So he will not be onboarded because there's no services that we are going to purchase from them. So any facility that was previously on NHIF has been onboarded. And the new ones that have come, who have been waiting, or who have now seen that there is an opportunity, have also been onboarded. And you also need to realize that all SHA is the base payer. So meaning, if you have your private insurance, the first charge is on SHA. So any services that you get, your SHA pays. So what does that mean? To the person who has a private insurance, you will now not be able to exhaust quickly your benefits for the private insurance, because your SHA benefit will cater for the
So you start with the SHA, then you move to your private card?
Yes, for example, you need a hip replacement.
I don't know whether that is what is happening, though.
But you need to have a proper discussion with your insurance.
Yeah?
That is what's supposed to happen.
Yeah?
That's what's supposed to happen, and this is now for the first time we said SHA is the base payer. So if you need a surgery, for example, and the amount SHA is going to pay is 350,000, SHA will pay first. If you have registered and you have paid up, SHA will pay the 350,000. Your private insurance will pay if there is any top-up needed. And the top-up could be 10,000, 20,000, 30,000, depending on where you have sought that services. So you still need, and that is the policy for even private insurances, that first charge is on SHA, second charge is on your private insurance.
There was this fear that if you walk in a private facility with the NHIF card, data wachukui, they will not even attend to you. They want the other cards. I don't know whether that, what is being done to change that narrative? And also, when you talk about facilities that have not been onboarded, there was talk that a majority of the private hospitals are still a bit skeptical based on what they've gone through under NHIF, the disappointments. I mean, what is being done to change this? So
the disappointment, what we are doing to change is what the president announced, which was to pay the pending bills. And we have received resources from the different MDAs and ministries, and we have paid this week, and there's more we are paying by the end of the week, and there's more we are paying again next week. So what actually, if you talk to the providers genuinely, not this assumption and rumors, they will tell you that they have been getting paid regularly over the last 1.5 months to 2 months. We are trying to clear as much as possible all the pending bills from which was left by NHIF. So the providers currently, if you talk to them, they will tell you this, for the first time, and this is the other thing that you people need to realize, is for you to be onboarded, it takes less than, actually it's real time now. You get your license from KMPDC, you are licensed, you are empaneled by SHA immediately. You go online and do the e-contracting as a facility. Do you know how long that used to take?
How long did it used to take?
2 years.
2 years?
Yes. Because they used to get license, people used to plan when they are coming to inspect your facility, do the inspection, write a report, send it to headquarters, wait for the board to sit, send it to the Attorney General for gazettement, wait for you to be allocated, given a contract, allocated a code, open an account. It used to take a total of 2 years. Now all that work can be done in a week. And it's the law.
Another interesting scenario based on what SHA has also said, if you look at the claims that have been lodged on the system, as at 27th of this month, totaling to about 1.3 billion shillings. We are excited because we are seeing most of the claims are coming from public facilities. Number one, Kenyatta National Hospital, the public wing, not even the private wing, followed by MTRH, Kenyatta University Teaching Referral Hospital, and then Nakuru, where the gentleman came from, is among the top 4. So we are actually achieving our objective of shifting services from prioritizing public health facilities, because there has always been this hue and cry that NHIF used to prioritize private hospitals at the expense of public hospitals. And that is very exciting. If this could go to the lower level, level 4, level 3 facilities, it would be very, very important, because majority of primary healthcare facilities are actually public owned. Many private facilities don't invest in primary healthcare facilities because of the low returns. Yet, we know very well for us to be able to achieve a universal health coverage, that is the place for us to be able to invest and shift traffic. So you can be able to see the statistics are trying to show the real picture of the whole intent of moving towards this direction.
Yeah, there's a question for you.
Very nice.
No, just to add on to, before you ask him, the 1 billion plus is services to patients.
Yeah.
So if the system was not
these
working...
are claims that have been completed?
Yes. So if there was no one who was getting, and it was all doom and gloom, people were paying cash, we wouldn't have a claim worth 1 billion. Ask any private insurance in this country whether they receive even 1 billion claims in 6 months or a year. Most of them don't see claims worth 1 billion. It's too big for them.
All right.
And this is just 27 days, and it was
within 1 month.
and with the first week of turbulence and second week, I could even say that is just 2 weeks claims.
All right, DG, there's one Jason Nyantino. He's asking, let the DG explain clearly what the 4 new laws will do exactly. It is not very clear for him.
Okay.
And of course, there was also the other question he's asking about the primary health care in every response. What exactly is primary health care?
Digital.
That was just
primary health care.
Nyantino asking this question.
Primary healthcare is basically services that are received at the lowest level in terms of our healthcare system. We have what we call Kenya Essential Package for Health. Level 1, which is not a structure, but a community-level services where the community health promoters work. They visit households and they have done an impressive work. They have registered more than 63% of the entire households in the country into the electronic community health information system. They have screened more than 6 million people for diabetes. They have screened more than 4.5 million people for hypertension. They have screened more than 4.5 million children under 5 for common childhood illnesses like pneumonia, malaria, diarrhea, and malnutrition. A figure that would have taken us probably 2-3 years to be able to achieve without their effort. And basically then the primary healthcare fund is the services that you are going to be able to receive way back from the household level through the community health promoters to the dispensary and the health center. So the primary healthcare fund is supposed to cater for that service. It is both inpatient, outpatient services, including screening, treatment for common ailments, and that is for free. All it requires is registration. We passed the second law, the Facility Improvement Financing Act. This is supposed to ring-fence resources generated by the health facilities. That money generated by Mbagathi Sub-County Referral Hospital should stay within that facility to be able to improve it. Previously, what used to happen is that the hospital will be able to generate money, but that money could be invested anywhere else. It could be used for benchmarking to Rwanda, to put a gate somewhere. It could be used for anything. But now we really want to be able to invest all the money from the health ecosystem back to be able to strengthen our health systems. Then the Digital Health Act. And the Chair talked about this in terms of now reducing the human interface in terms of our interactions. And that is why you have seen like pre-authorization time reduced from 1 week to 78 minutes. And we believe we can even be able to get better. Reducing the human interaction with the system, using digital technology, including artificial intelligence to be able to offer services. Then the Social Health Insurance Fund, which we have talked about, bringing everybody in the spirit of solidarity. And what was the fourth law, Chair?
Those are the four. The primary health care.
Yes, and the digital health.
All right.
Yes.
Chair, as you also add on that, there's a question on how you have addressed the budget deficit that you experience, especially considering how much was considered for the primary healthcare fund in this year's budget, what was allocated vis-a-vis what you had anticipated to receive, and also on the emergency, chronic and critical illnesses fund that required a very huge budget. The numbers I have here, you can correct me if I'm wrong, 75 billion each year. What the government allocated is only 2 billion. I don't know how you have addressed this funding crisis.
So what we have done is we have prioritized in terms of what are the services that we are able to cover currently and what are the tariffs that we are able to pay currently. So as we progress and more funding becomes available, we will increase the tariffs and the benefits so that we are able to cover. But what we have done is and that's why you will find people are saying, why do you have dental 2,000? That is part of the prioritization. You need to look at, yes, dental is important, but is it dental that will make a family poor and that will be make them catastrophic spending, or it will be a dialysis which will cost them $1 million to cover, or cancer which will cost them almost $1 million, or a surgical procedure that needs 500,000. So that's the kind of prioritization that we have done to see what do we need urgently that will make people poor that we need to cover urgently, and then now subsequently increase the scope of benefits and the prices so that now these things become readily available everywhere with no extra cost to the patient.
All right. As we wind up, because I'm really pressed for time, your final thoughts, what assurance are you giving the nation? Because, Dr. you suggested the train has already left the station. We are moving.
Completely, yeah? We are moving.
But the fears that have been there, the hiccups, the complaints, what assurance do you give the nation that we are on the right trajectory?
The assurance that we want to give the nation is, as I've said, is that the train has left the station. We are picking speed, but we are cognizant of the problems that will still abound. And the best way for us is now we have decided to decentralize, go to the regional and branch level of SHA to be able to bring multidisciplinary teams of health facilities, ICT officers, the regional managers, the branch managers to be able to go to the individual facility and troubleshoot and offer a solution. We are also trying to address the issue of culture change, moving from a manual system into an entirely electronic system requires also culture change. Some people are getting to use these gadgets for the first time, and therefore you expect them to be a bit hesitant. And of course now the next thing that we need to do is to be able to up our game in terms of communication. There are lots of good things in this system that we need to embrace. Probably we have not communicated that best, in the best way possible to the common mwananchi, and we'll go the whole hog to be able to ensure that we pass this message in a language that our people can be able to understand. And finally is to urge everybody to take this opportunity. Please register. Even if you don't pay, you will be entitled to the primary healthcare fund services at no fee, and also the emergency services. And once you go through the whole log, you do your means testing, if you pay, you will be safe. Going forward, you can be able to access even a bigger menu of services.
Mine is just to urge, as the DG said, Kenyans to register and contribute. I think we understand the word Harambee. We participate in Harambees in our WhatsApp groups. This is a national Harambee where everyone contributes as per their ability to pay. The same way when we go to Harambees, people pay as per their ability and what they can afford. Someone will contribute 10,000, another one will contribute 50 shilling. No one is chased away, and that is the spirit of social health. Social health insurance is you bring what you have. That now helps us all to get services. So we urge the media to help us in terms of propagating the importance of this Harambee and hold us accountable on the service delivery part. But first of all, let's agree that this is important and it's in our benefit that we have a social health insurance that's working, that's beneficial to everyone. Hold us accountable on the part of service delivery so that we also remain steadfast in keeping our promises and addressing issues as they come. So that balance is what we are urging and what we hope we will get. Thank you very much.
All right, Daktari.
Yes.
Quite interesting that media has been, you are on media, you have been here for a good 1 hour just to convince Kenyans that this is working. I mean, we have done our part. You've been here for a good 1 hour just explaining to us where we are going with it. Yeah? So media has played its role. But thank you so much, Dr. Abdi Mohammed, the chairman of the Social Health Authority. I've also been having this conversation with Dr. Patrick Amo, the Ministry of Health's Director General. Thank you once again, gentlemen. Of course, it's a conversation that cannot end here. We keep on talking about it as we seek, how the road to this transition to the new healthcare system is looking like. My name is Safina Chengoma. It's been a pleasure doing this for you since morning till now. But keep watching Citizen TV. There's still a lot that we're working on for you. For now, it's a wrap.